Bismillahirrahmanirrahim. So we are here with the hypermature cataract, and we were discussing. You see, the difficult the case is, there are more options and more controversies. The bigger the challenge, greater the controversies. This is a general rule, because in routine cases there may be a regular single method to manage, but in challenging cases everybody comes up with new ideas and different views. So hypermature cataract is again a kind of challenge in phaco cataract surgery. तो पहले थोड़ी सी पोएट्री सुन लें। दीदार से मखमूर जरा मेरी नजर कर, फिर देख किसी रोज मेरे दिल में उतर कर। तुम भी कभी ज़ेरे नकाब आओ तो अच्छा, निकले ना कभी चांद बदली से उभर कर। शायद भी है हकदार भी है एक जमाना, हम पे भी अनायत हो कभी हम पे नजर कर। नींद से बोझल है तेरी पलकें हमदम, हम जाग के कर लेंगे तू सो के सहर कर। शायद उसे रात बुखार में मुब्तला था। तो चैलेंज हाइपरमेच्योर कैटरैक्ट में दो हो सकते हैं, एक तो विजिबिलिटी ऑफ द कैप्सूल एंड द सेकंड डेंसनेस ऑफ द न्यूक्लियस. So this is how we need to plan our strategy while managing hypermature cataract. Because we are not seeing the fundal globe and we have not examined the lens in a good high magnification with the oblique illumination and the slit lamp. So we are not sure whether before getting hypermature, what was the type of this cataract. There may be a kind of posterior polar surprise here. There may be some kind of posterior capsular defect underlying. So the lesson is that only experienced surgeons should take up these cases, because there can be a surprise. And then we need to carefully classify whether it is hypermature milky type or dense hypermature type. And in both these cases and both these kind of unexpected events can end up into corticocapsular adhesions, leading to more chances of PC dent and nuclear fragment dislocation. The second thing, because the cataract is dense, you will be needing more phaco energy to emulsify it. So there are greater chances of corneal burn and endothelial decompensation. So this is a preoperative examination. As we see, it is a dense brown cataract, maybe also we grade 3+, there is no frontal globe. And as looking at the pupil, we are able to perceive that there will be no milk. So if we are able to stain this capsule, probably we will be able to have a good Rhexis. The concern in this dense hard nucleus will be how to take this nucleus safely out, saving the endothelium. We inject here, then we use dye to stain the capsule, and then we wash the dye. The capsule is well stained. We can use diluted adrenaline to dilate the pupil. Heavy viscoelastic serves good purpose, but if you enter through a small port, even methyl cellulose will do the job. And we are able to create a good CCC, continuous curvilinear capsular Rhexis. So these dense cataracts are not, Rhexis is not the problem. Nuclear emulsification is the problem. And after completing the capsule Rhexis with the help of needle, and the second thing is only those persons should attempt these cases who are good with the forceps as well, because you may need forceps at any given time. And this nuclear rotation is not mandatory. One can avoid it if possible. And as long as the phaco technique is concerned, you can use divide it in 4 quadrants. I had been doing it, and my approach used to be that I create a wider tunnel so that I am able to debulk the nucleus. But even better technique is kind of quick chop. that you keep on cracking it with the help of a good second instrument. And I always keep on stressing on use of non-dominant hand and second instrument in Phaco cataract surgery, that you just grab it with good vacuum and excellent Phaco with good fluidics, hold the nucleus and keep on chopping it in multiple places. And you can create a kind of femtocataract like picture. You can divide it in 8 to 12 chunks, and then the chunks will start coming. If you are kind of away from the corneal endothelium and doing your Phaco inside the bag, then the risk of endothelial damage is not an issue. Then Phaco time is not an issue. The Phaco time and the corneal complications will only be more if you are using Phaco for long, pressing the Phaco paddle too much for long durations, and you are doing too much work in anterior chamber. If we are able to divide it with patience inside the bag, it's not a problem. So once we are able to emulsify the nucleus, the lens implantation is not an issue. Here is the kind of nucleus is not an issue in this case, because once we are able to create Rhexis somehow or other, the nucleus emulsification and chopping will not be a big problem, because it is a kind of brittle and not that hard. Whereas in this case, the Rhexis is going to be an issue because of the intralenticular pressure is very high, because of the milk, because of the swelling and imbibition of the cortical matter. So we can expect more concerned we will be with the Rhexis in this scenario. And here the use of heavy viscoelastic will be more helpful. So the steps are same: deepen the anterior chamber, the Phaco incision, and stent the capsule. Once the capsule is stained, the Rhexis was started. I always use a little viscoelastic over the cornea. It gives a little magnification and very crisp, clear view. And you are free of help of assistant to keep on dropping. And once I started Rhexis, I was not able to complete it. I realized that I am not able to control it. So injected viscoelastic again, started at other place. So this case I have intentionally included in this discussion, because the success stories are easy to share, but even experienced surgeons do end up in these cases once in a while with Argentinian flag. So the technique here we have used is double D technique, that after I noticed that the rip is not getting under control, I divided the Rhexis in two halves. The inferior half D was completed, and then the superior half was completed, and that rip was centered. So even if the little rip occurs, just sit back, take a deep breath, relax, and complete the Rhexis again with two Ds facing each other base to base. So once we are able to complete it, the rest of the procedure is relatively easier as compared to the previous scenario where the cataract was dense. This nucleus is always, because of the surrounding milk and emulsified cataract, easy to rotate, easy to manage, easy to crack, and easy to aspirate. So just need to be cautious that we don't manipulate it too much against the direction of the rip. And the pupillary plane Phaco is the objective, and we can always protect the posterior capsule near to the end by intelligent placement of our second instrument just beneath the Phaco tip. After completion of the Phaco, rest of the job was relatively easy. We just implanted the IOL, and again the message here is that we need to implant the intraocular lens away from the direction of the capsular rib. We will put, if the rib is in quadrant, we will position the IOL haptics infradial and supratemporally away from that direction of the Rhexis. And this is another technique of Rhexis in hypermature cataracts, which is known as spiral Rhexis. We again inject the air, inject the viscoelastic, deepen the anterior chamber, and as you can notice, we start right from the center and a little tongue is raised. We are not trying to attain the desired size right in the first step. So this will just keep on extending like a spiral. The first round is completed 2 millimeters, then gradually the flap is being extended. The size of the Rhexis is being extended like a spiral. It gives a lot of safety and decreases the chances of the rip, because you have nicked it in the center. If there is a milk, it will also ooze out, and you can always visco express this milk. Don't try to take your Simpo in, because the collapsing of the anterior chamber during this maneuver may be disastrous. So we have to keep the chamber deep. Keep your anterior chamber maintained in these complicated cases. And after completion of this spiral capsular Rhexis, rest of the procedure was completed successfully with the kind of quick chart variation. We just cracked it and kept on cracking it until a chunk came, and once a V-shaped chunk comes into the Phaco Ejaz, rest of the life becomes easier. So this is known as spiral Rhexis, which can be of great help in cases of hypermature milky cataract. And here you see the single multi-piece lens is planned. This is my routine, because these cases can be there with unexpected outcomes. So I always have a backup, or I always plan with a multi-piece IOL, so that I'm able to place the lens in the sulcus as well in case needed. Because we have to remember one thing: the square edge single piece lenses are contraindicated to be placed in the sulcus. They give rise to similar kind of iris chafing of the posterior surface and chronic uveitis and glaucoma. So single piece lenses ideally should not be placed. The ideal place for single piece lenses is capsular back. So this is how we end up our presentation. दीदार से मखमूर जरा मेरी नजर कर, फिर देख किसी रोज मेरे दिल में उतर कर, तुम भी कभी ज़ेरे नकाब आओ तो अच्छा, निकले ना कभी चांद बदली से उभर कर, शायद भी है हकदार भी है एक जमाना, हम पे इनायत हो कभी हम पे नजर कर, नींद से भोजन है तेरी पलकें हमदम, हम जाग के कर लेंगे तू सो के सहर कर, तुसा सो के रात गुजार लेंगे, असा रो के रात गुजार लेंगे. Thank you very much.
Thank you very much, Dr. Mazhry, for having such a nice presentation. Because we are running short of time. The next
We see a lot of